Hello and welcome to this presentation, part 2 of the foot. It's a continuation of part 1. So if you haven't already seen part 1, we recommend that you do, or at least aware of its content. So we'll continue to present you with a series of cases, fractures, dislocations, fracture dislocations, and then we'll go on and look at Kohler's disease and Charcot's foot. Hope you enjoy.
Metatarsal stress fractures are particularly common. A stress fracture is an abnormal load going through normal bone, in contrast with a pathological fracture, which is normal load going through abnormal bone. A stress fracture of the metatarsal is frequently called a march fracture, after new military recruits sustaining this type of injury. What happens is that the body identifies areas of weakness, and so what it tries to do is it tries to build up new bone formation to make that area stronger. However, during the process of building new bone formation, in that small window, it's actually weaker. And what happens is that you get this periosteal reaction where it can be quite fluffy, and you tend to see it on the second and third metatarsals. This periosteal reaction may take 2 to 3 weeks before it's visualised, so initially patients may present with absolutely normal x-rays. But certainly when you're looking at a foot x-ray, scrutinise the metatarsals very carefully to make sure that you don't miss a subtle underlying stress response. So what is it? It's a stress fracture where it's the mid-diaphysis of the third metatarsal. How? You've got this acute periostitis. Remember, the outer layer of bone is called the periosteum, and itis means inflammation. So essentially, acute periostitis is inflammation of the periosteum. This is quite an impressive x-ray. We can see two quite distinctive fractures of the third and fourth metatarsal. Now our third metatarsal is minimally displaced. You've only got the tiniest step in the cortex medially, whereas our fourth metatarsal, there's marked lateral displacement and overlap. The thing that you have to really worry about with this injury is whether there are further more subtle injuries that are associated with it. So what's the thing that I keep talking about with foot x-rays? That's right, a fracture dislocation at the base of the second metatarsal, otherwise known as a Lisfranc fracture dislocation. So on our DP view, if you remember, the medial cortex of the second metatarsal must align with the medial cortex of the intermediate cuneiform. And on this view, it seems to be in alignment. Okay, let's have a little look at the oblique view. And suddenly now all is revealed. So we can quite clearly see that on an oblique view, the lateral margin of the second metatarsal should align with the lateral margin of the intermediate cuneiform. And we can quite clearly see that there is malalignment here. So this is actually a Lisfranc fracture dislocation. It's called a Lisfranc injury after a surgeon who worked in the Napoleonic Wars, Lisfranc, and he used to perform a amputation through the tarsometatarsal joints, hence being called the Lisfranc joint. Now it's normally caused from either fall from height, a step off the curb, or classically, which is the injury with the Napoleonic times, when you get rotation around a fixed forefoot, i.e. when a rider falls off a horse and their foot remains caught in the stirrup. If you see a Lisfranc fracture dislocation, you should also go and perform a lateral view. But this is also quite interesting. If we look carefully, you can now see this tiny bone fragment between the second and third metatarsals. Now, it's quite difficult to say where this bone fragment comes from. It could have come from the second metatarsal, it could have come from the third. This patient's going to have a CT, but you should mention that you do have an osseous fragment in this location. So what is it? It's a Lisfranc fracture dislocation, where it's the base of the second metatarsal for the fracture, it's the second tarsometatarsal joint for the dislocation, and it's the mid-diaphysis of the third and fourth metatarsal. So it's undisplaced at the second and third metatarsal. You've got lateral displacement of the fourth metatarsal, and you've got homolateral subluxation of the second tarsometatarsal joint. So what do I mean by homolateral subluxation? Well, if you think about it, the term homo means same. So what that means is that the bones are all moving in the same direction, and then you've got lateral, meaning that's the direction it's going in. So a homolateral fracture dislocation is when the metatarsals all dislocate or subluxate in a lateral direction. In contrast, you can have a divergent Lisfranc fracture dislocation. Now, these really aren't that common. So what do I mean by divergent? Well, divergent means that generally the first metatarsal dislocates medially, whereas the second through to the fifth dislocate laterally. So essentially they move away from each other, or they diverge away from each other. This is a really complex injury. You can see there's a massive chunk missing out of the first metatarsal, there's chunks missing out the second. This second metatarsal head has been completely obliterated. There are fractures through the phalanges, and if you look, fractures through the head of the third metatarsal and all through the bases of the fourth and fifth metatarsal. So it's a really complex image, and it would definitely require CT for further evaluation. And now on our lateral view, we can see how the metatarsals have actually moved dorsally, in particular the second and the third, and of course the first. What is it? It's a Lisfranc fracture dislocation where the tarsometatarsal joints, bases of the metatarsals, head of the second metatarsal and adjacent proximal phalanx, have divergent dislocation with comminuted fractures. Don't worry too much about this image. This is highly complex and you wouldn't really be expected to look at it in the exam. But what I want you to bear in mind is just to note that this is what a divergent Lisfranc fracture dislocation looks like. There are several different types of navicular fractures, and in this case we have a sagittal fracture running through the body of the navicular, separating it into both medial and lateral components. If you look carefully at the DP oblique, you can't actually appreciate it. Hence, this is a really good example of the need to have more than just one view for imaging. So what is it? It's a fracture where it's a navicular and how it's slightly displaced. The second type of navicular fracture, which isn't demonstrated on this image, is when you have a sagittal fracture that separates components into the dorsal and plantar components. And this one won't actually be visualised on either a DP or a DP oblique, and you'll only be able to appreciate it on the lateral view. So the previous X-ray, where the sagittal fracture separates the fracture into both the medial and lateral components, you will see that on the DP oblique view and occasionally the DP. Whereas a sagittal fracture where it separates the navicular body into dorsal and plantar fragments won't be visualised on those two views, and you will need to do a lateral. Now this is another common fracture of the navicular. This is a fracture of the dorsal cortex, and it's a small avulsion fracture, and again this won't be appreciated on either DP or DP oblique view, and this really does demonstrate the importance of why you need to have a lateral view if you ever have any question about injury to the tarsal bones. And we can see that it is slightly displaced. So here is the dorsal surface, and we can see it's been retracted superiorly. So what is it? It's a fracture where it's the dorsal surface of the navicular and how there's slight displacement. So Kohler disease, it's not a disease per se. This is actually a self-limiting avascular necrosis. So what do I mean by self-limiting? Well, basically it means that the patient will recover from it. It's only like this for a short period of time. And if you look at the medial cuneiform, the intermediate cuneiform, the lateral cuneiform and the cuboid, we can see how all the bones have a similar density. They're all of a normal size and shape. And then in comparison, we can see the navicular, which appears very flattened and sclerotic, and sometimes it could even appear fragmented as well. So flattening, fragmentation and sclerosis is kind of the three buzzwords that you use when you describe an avascular necrosis. So whether that's an avascular necrosis of the hip in a child, such as Perthes disease, or whether it's avascular necrosis of the lunate with Kienbock's disease in the hand, you know, you always kind of use these words of flattening, fragmentation and sclerosis. So what is it? It's avascular necrosis, Kohler disease, where the navicular, how, sclerosis, flattening and fragmentation. It's quite common to get tiny avulsion fractures on the lateral margins of either the cuboid or the calcaneum, so it's important to scrutinise the area carefully. We frequently get accessory ossicles at the junction of the base of the fifth metatarsal and the distal lateral margin of the cuboid, that's os vesselineum. And so we need to be able to differentiate between an accessory ossicle and avulsion fracture. So an avulsion fracture will have a break in the cortex, and here we can quite clearly see this cortical, this sclerotic line, this cortical margin, and suddenly it's completely lost. And then again you can see the distal aspect of the cortical margin, so we can tell that this is actually a fracture. Whereas an accessory ossicle, this is going to be smooth, it's well rounded, there's no adjacent disruption to the host bone indicating that it's been pulled off from that location, and so therefore you can differentiate it. You do need to learn your accessory ossicles, that's very important for your exam, because you need to be able to recognise that it's normal, and two, you need to be able to describe it adequately. And now we can clearly see that break again. So we can see if we go around the margin of the cuboid, we've got a completely intact cortex until you get to the lateral distal margin. You can see that there's a small step there indicating that you have an avulsion fracture. So what is it? It's a fracture where it's the distal lateral margin of the cuboid and how it's slightly displaced. And now we have an avulsion fracture at the anterolateral margin of the calcaneum just here, and that shouldn't be confused with the accessory ossicle os peroneum. So as I've described earlier, an accessory ossicle which you looked at, it was on the first couple of slides in the part 1 of the foot presentation under normal anatomy. So os peroneum, it's smooth, it's rounded, it's well corticated. Whereas here, although we can't actually see the adjacent site where this piece of bone is pulled off from, we can see quite clearly that this is just a sliver of osseous bone. It's irregular in appearance, and also look at this gross soft tissue swelling here that helps to guide you into understanding that this is actually a fracture and not something to be confused with, such as an accessory ossicle. So what is it? It's a fracture where it's at the lateral border of the calcaneum, how it's slightly displaced. We're very familiar with burst fractures of the calcaneum caused by compressive force, such as a fall from a height. But you can also get this additional area that can fracture. This is the anterior process of the calcaneum, and it's the site of the Burford ligament insertion. And what happens is that you get an avulsion fracture through here. In this particular case, this is an undisplaced fracture. We can see that the cortex is completely in alignment, so you just have that sharp lucent line indicating that you've got a fracture, but it's undisplaced. Okay, just while we're looking at this image, pay close attention to the lateral margin of the cuboid. Here is a bipartite, so bipartite meaning by two, so you've got osperonium, but you've got two accessory ossicles of osperonium because it's bipartite, a bit like a bipartite patella and such. Note that they're very smooth, they're well rounded, they're well corticated, and so these shouldn't be mistaken for a fracture. So here is another view of the anterior process of the calcaneum, which we see on our ankle view, and you can see that there's just a small tiny avulsion fracture of the anterior process. So you can appreciate the anterior process on your lateral view. Please always check it, although to be fair, this area is normally best appreciated on an oblique. So what is it? It's a fracture where it's anterior process of the calcaneum and how it's undisplaced. Please note that I've put these two views in, but they are two different cases, so just so that you don't get confused. So a Charcot fracture dislocation involves the mid-tarsal joints. So basically the talonavicular and the calcaneocuboid joints. And in the way that the Lisfranc is named after the Lisfranc surgeon in the Napoleonic Wars, Charcot is also named after a surgeon in the Napoleonic War. And he used to perform amputations through the mid-tarsal joints called a Charcot amputation. Now, although it typically, if it's caused by trauma, it'll probably be from falls from a height or from a motor vehicle accident. But to be perfectly honest, you're more likely to see it because of diabetic neuropathy. Okay, so let's have a look at this image, and what I want you to pay attention to is looking at the joint space. So if we look at the first tarsometatarsal joint, we can see a nice even joint space. We can clearly see a gap through it. And if we look at our medial cuneiform in alignment with the navicular, again the joint space is preserved. But after that, it all starts to get a little bit complicated. So if we look at our navicular coming around here, we can see that the talonavicular joint has been completely lost. And in fact, the talus is now completely overlapping the navicular. If we look at the lateral margin of our cuboid, we can see that suddenly there's no articulation there of the calcaneum with the cuboid. And now on the lateral view, we can quite clearly see how the mid-tarsal joint has dislocated dorsally. Do you remember that I said that this normally happens with diabetics? Well, look, here's fairly extensive vessel calcification, and this is normally is frequently associated in diabetes. So I suspect that this is because of diabetic neuropathy. So what is it? It's a Charcot dislocation where it's the mid-tarsal joints and how there's dorsal displacement. Okay, finally, I'm just going to briefly touch on a Charcot joint. I've already discussed how with diabetics you quite often get peripheral neuropathy, and that can lead to osteomyelitis or a Charcot joint. So osteomyelitis is basically a disease of bone. It's infection of bone, and you tend to see these through the metatarsals and through the phalanges and occasionally in the calcaneum. In contrast, a Charcot joint is a degenerative disease of the articular surfaces. So it tends to affect the midfoot and you get this progressive destruction. And basically it affects those who have abnormal pain sensation and proprioception. And what happens is you get this increase in density, you get destruction, you get debris, and you get disorganisation and dislocation. So that's just something to be aware of, because I'm sure you'll frequently see it in clinical practice.